The doctor is in. How are you guys? The doctor is in. We are here. It's Wednesday. We just got off the phone with Dr. Mo, who is on her way to Sedona. Her birthday was yesterday and she is celebrating. So, but I have like my favorite docs on the phone. So don't tell Mo I said that. No. No, I love her. But my doc, Regina Hampton. Say hi, Regina.
Hello, hi everybody.
And Dr. Kalu, Dr. Agori, my other favorite doc. So they are both on our medical advisory board and they are amazing, amazing badasses. So they're going to like fill in Mo's shoes today with us and talk about mastectomies versus lumpectomies. And then I have my precious breasty friend, Sybil Smith, and she's going to share her story and talk about how I beat her up over this topic. And then thank God we became friends after I beat her up and we had like a knockdown drag out fight in front of Dr. Hampton's office, right? So let's bring it. So basically, this is something that's near and dear to my heart because, you know, I really believe that our Black breast cancer is a different disease. And I'm trying to figure out why and how and what we should be doing differently, right? So, and I'm going to let you guys speak to the data and sort of the medical opinion, but I believe you should pull out all the stops, right? Especially when you start talking about triple negative and I don't know, but I mean, I don't scientifically, you don't have to get a mastectomy. And I guess it's sort of my philosophy that why not? Why not just minimize your risk, right? So I think we should start with Sybil's story because she's such a success story. And then I'll let you guys kind of speak to the science, okay? Because I'm a crazy person over this issue and Sybil will tell you that, right? So,
well, I want
your story, honey.
Thank you for giving me this opportunity because, you know, I'm just as passionate as you are, I am as well. So my breast cancer journey started in 2016. I was diagnosed, I went for my regular mammogram and I was diagnosed initially with stage 1 triple negative breast cancer. I had lumps, very small lumps in 2 areas in the same breast, in my right breast. And of course, that was my first opinion. I sat down with the surgeon of the hospital that found and did my mammogram. But of course, me being obsessive compulsive person that I am, I went and had a second opinion at Washington Hospital Center. And they said pretty much the same thing. You know, I asked, what did they think I should do? If it were their mother, their wife, their daughter, their loved one, what would they advise them to do? And they each opinions basically said that they would tell their loved one to have a lumpectomy. And I said, well, my daughter bashed me about it. She basically bashed and said, Mom, you need to remove your breast. Why are you keeping it? And, you know, that's ridiculous. And so, of course, that my next question to the doctors, because I was going back and forth, what did they think about me having a mastectomy? And they said, well, you know, your cancer that you have, and I don't like to say your because it's not my cancer, but the cancer that you have, it still depends on you, what you feel would be best for you. A mastectomy is not necessarily something that you would need to do. That would not be the treatment for you necessarily. That would not be the best treatment for you. So I basically opted and got a lumpectomy. I had actually need to go back because they thought I had cancer in my uterus also. So they did surgery on that first, did an exploratory surgery. I don't know if you know that, Ricky, if I told you that, but it was, yeah, but it was nothing, there. It was just really fibroids, right? So they went ahead and did that, took everything, all my organs, did exploratory, checked, you know, the surrounding organs. And then I had the breast surgery. So after the breast surgery, of course, I had the radiation. I had chemo, and then I had radiation. the chemo was, I think it was 6 rounds of chemo, I want to say 6 rounds. And then I had the 36 weeks of radiation every day. I was going to the hospital every day. So I opted to go with Washington Hospital Center. I had, one of the top surgeons there, Dr. Bovier, was my surgeon. You know him, Regina, because we talked about it. And Dr. My oncologist, but I don't need to throw names out there. But anyway, they did a phenomenal job. And me being the prayer warrior that I am, I said, I don't use the word that I'm just in remission because I can't stand that word. I use the word that I've been healed because
Yes.
I believe
Yes, amen. Yes.
speak things into existence, and though it will be. So I told my doctors, I said, you sure y'all did the best thing for me? Because I then start questioning things. So a year went by, I had and I'm fast forwarding on this because I don't want to take too much time, but a year went by and I had gone to have my annual, no, 6 months, maybe 6 months, maybe it was, I can't remember if it was 6 months or a year now, but I had my annual and they saw cancer in my lymph nodes. And after that, I met this wonderful person. This was during the time I had just found out, and I was helping, doing some work, volunteer work with Washington Hospital Center, and I met my wonderful, now breasty, Ricky. And I was still kind of upset about that because oh my God, I'm supposed to be healed and this is not supposed to come back. And Ricky, we were talking and she said, well, I said, yeah, I'm a survivor, but unfortunately, I had triple negative. And I don't know if I told you came back, but she said, well, why didn't you have a mastectomy? And I said, because that wasn't the road or the treatment that my doctors suggested for me. Even
And we did not know each other then. We had just met.
Did not know each other. I just met her. I mean, I just met her. Like we were next to each other tables, discussing, breast cancer and different things to people, right? And she went off. She's like, I can't believe you should have had a mastectomy. And I said, well, no. I said, that wasn't my regimen. I needed to have what I needed to have. I had a lumpectomy. That was best for me. And everyone, does not need to remove their breast. Well, why do you think so? You need to talk to my doctor, Dr. Hampton. And I said, okay. So she pushed a card to me. And I said, okay. I said, well, I know I trust my doctors and I believe that they did the right thing for me. But in the back of my mind, I still had questions because this crazy woman is talking to me about triple negative and the, statistics and the percentage about Black women and the survival rate. And I was just diagnosed again with, having cancer in my lymph nodes. And she didn't know it. Ricky, you didn't know this.
I didn't know
I said, okay, let me just see. So I called Dr. Hampton's office. And I went, she took me in, I think maybe within 3 days, because I was frantic. I mean, Ricky, you pissed me off so bad. I was so frantic. And I said, let me go and talk to her doctor. Now, mind you, this is my third opinion, right?
Right.
So I went and spoke to Dr. Hampton. I told her about Ricky. I said, I met this woman, one of your patients, and she talked highly of you. And I just wanted to know now you're my third opinion. And I just need to make sure everything is fine. What do you think I should do? And I gave her my full history. And Dr. Hampton said the same things that my doctor said, that was she would have done the same thing. And everyone does not have to get a mastectomy. And I'm going to need to talk to Ricky.
I know she called me and said, what are you doing?
About doing that. So again, that was I guess the overall, and I did wind up having my lymph nodes, and I don't know the medical term for it. When you have all of your I had maybe 39 lymph nodes removed. And they said I was going to get lymphedema 5 years later. I don't have lymphedema, but here we go again. Speak things as though they will be. So I went and had all of the opinions that I needed to have. And 5 years later, now it's 2021, I'm still here. I just had a full PET scan. There is no cancer, any evidence of any cancer in my body. And I tried to do my very best in taking care of myself. So my lumpectomy was the best option for me.
I love you, dear.
I love you more.
I'm
Thank you. I love your passion, and I'm glad you understand my passion as well.
Yeah, can beat you up. I know. Regina called me and said, "What did you do to that poor woman?" I know. It's okay, Ricky. So I'm sorry, but I don't know. But so okay, Doc. So here's the deal. The study just came out from Sweden where there's no Black people, but I even researched it a little bit, and it says, the data basically says, and you help me, a lumpectomy plus radiation is equivalent to a mastectomy if you're stage 1 or 2. Is that right? So,
Yes.
but where are the Black people in that study? They're definitely not in the Sweden one. So how do we know, like, why do we have a 39% higher recurrence rate? Why do we have a 42% higher mortality rate? Like, what is it about our bodies that doesn't work?
Well, I don't think it's a matter of the type of surgery. I think it's a factor of the type of cancer that we get as Black women. So, yes, the survival rates for when you look at lumpectomy with radiation versus mastectomy are equivalent. But there's also some other things that go into that. I mean, it's not just you get the lumpectomy. It's like you've got to have the lumpectomy and the margins have to be clear and negative. I've had some patients who've had the lumpectomy and say, all right, I'm done. It's like, no, we need to go back. The margins are close, the margins are positive. And I've had some women who've refused to go back to surgery. So, you got to have the right surgery first to make sure that you fall into that category where those rates are equivalent. But, I think when you talk about Black women, it's our cancers are different. And there is going to be a difference with triple negative breast cancer. Now, I think we're doing better in that, sort of 10, 15 years ago, everybody got surgery first and then got the remainder of their treatment, got the chemo last. Well, we've switched that order, and especially for triple negative patients. I mean, I try to, unless you have a less than 1 centimeter triple negative tumor, I'm voting for you to get that chemo up front, because that is the most important treatment. It ain't my surgery. The most important treatment for triple negative patient is that chemotherapy. And one of the good things about being triple negative and getting your chemotherapy up front is that triple negative patients are some of the best responders to the chemotherapy. So it really allows us to see what the chemo is going to do. And in about 60% of those cases, the tumor completely disappears even before we go to do surgery. So I think that's phenomenal. Those who have HER2 positive tumors, we get some of those same great responses as well. I'm excited because, we just treated, my practice manager. And yeah, she noticed after her second treatment, the mass started to disappear. By the third, fourth treatment, she couldn't feel it. When I went to do her surgery, she had a complete pathologic response. There was not one cancer cell left.
Wow.
Not one. So what do you do after that? What happens after you have had the chemo and there's no more visibility of a lump? How do you surgically remove it?
So it depends on what was the status before the treatment. So in her case, she was able to get a lumpectomy, and that's what she chose. It depends on how much tumor was there from the start. If there was a lot of tumor in different quadrants of the breast, so we divide the breast into 4 quadrants. So if you had it in multiple quadrants, even if you get a good response, you still would have to have a mastectomy. So it really just depends on where we started. But she had the option to do lumpectomy. versus mastectomy. She chose to do lumpectomy. Her lymph nodes were negative.
That's good. And she's
And
doing
if
it now.
Dr. Kalu has anything to add?
So I'm sort of on, as far as reading the study, on the Swedish study, I think I spoke to you briefly before this meeting with you about my thoughts on it. Just as you said, it's really what I sort of see as more of a population-based study. People in Sweden, women in Sweden, they're a different demographic than the women in the United States, different demographic than just the women in the African-American community. Not to say there are no Black people in Sweden, but I know there's not as many Black people in Sweden. I can only speculate they probably didn't have that many Black people, if any, Black women in their study. And coming from that demographic, as well as just different lifestyle, means different diet, different things within their environment, there's so many different contributing factors comparing breast cancer in America to breast cancer in Sweden. That being said, touching upon what you said, Ricky, in regards to Black women's survival rates compared to white women, and why do our bodies respond differently to cancer? Basically, I'm kind of paraphrasing what you asked me. I think in general, just as Dr. Hampton mentioned, do have different cancers, but for the most part, for all women, Black, white, Hispanic, most women in general, when you think of all the breast cancers going on within these separate communities, most women have estrogen positive cancers. It's just that as African American women, we just have a higher percentage of triple negatives, being that, completely, if we look at all communities, maybe up to 15% of women collectively have triple negative, but if you see African American women, it'll maybe go up to maybe 30, maybe 40%, upwards to 40% of Black women with breast cancer will be triple negative. Still means majority of us have hormone receptor positive cancers, but still collectively, we still have lower mortality rates, or higher mortality rates, and lower survival rates. So you're right, there's something going on, I believe, within the biology of women of African descent and breast cancer that just, in my opinion, is a little bit different than breast cancer in or women who are not of African descent. And I think when we're approaching treatment options in regards to surgery, you can't really comment on different chemotherapeutic options, but in regards to surgery, I believe every woman's situation has to be taken into account. There's so many different factors. Of course, you're thinking about the kind of tumor they have and their stage of presentation and whether or not they have, whether or not the opportunities present themselves for having chemo up front or they don't need chemo, or those different factors, but also what the surgery means to them. Because we do know historically that mastectomy is, if I say in a broad term, that having a mastectomy with a lymph node biopsy or lymph node dissection is equivalent to having a lumpectomy with a lymph node biopsy or lymph node dissection, as far as overall mortality rate, meaning, a woman's lifespan won't be affected depending on which surgery she has, assuming she has the appropriate surgery, lumpectomy with radiation versus mastectomy. If you put
Go
that
back for 1 second. Explain what a dissection is to our audience.
So lymph node dissection would be if somebody presented with breast cancer and we know up front that they had cancer within their lymph nodes, you would take a majority of the lymph nodes within the axilla. You're thinking of taking the lymph nodes that primarily drain the breast that are under the armpit, versus someone who presents with, clinically, there's no suspicion of cancer in the lymph nodes, so you do a lymph node biopsy, meaning with the surgery, you just take maybe 1 to 3 lymph nodes, they're tested, in the laboratory to see whether or not there's cancer there. So it sounds like, Sybil, what happened with you was initially they did the surgery and no cancer was found in the initial lymph node, maybe a lymph node biopsy. Then subsequently, months later, when they did follow-up testing, they found positive lymph nodes. So they went back and ended up taking, instead of 30 plus lymph nodes, to completely, take away any local, sort of local evidence of any tumor involvement.
Exactly.
So it sounds like that's what, so we do know surgically, if you do one versus the other, lumpectomy plus the addition radiation versus mastectomy, that for most women, the survival benefit is roughly the same, meaning that one isn't better than the other. This is traditionally what we've been taught, at least for me coming up, in my training. The only caveat is because you have a breast left over with the lumpectomy, you do have a higher chance of having a local recurrence over the course of your lifetime. But the idea is that even if you do have that local recurrence, it should be or would be treated appropriately, and it shouldn't, take away from your overall life expectancy. It'll definitely be something that, it's a lifestyle modification, something that obviously you don't want to deal with again, but overall it shouldn't affect your survival. You'll still live the same, length of, many years to come. But, that sort of learning, I don't think took into account the variations in breast cancer that we're now learning and seeing and identifying. And it didn't take into account breast cancer in other communities, particularly minority communities, because this was all based on data that was all from, clinical trials that we know historically and continually have majority women of European descent in. So it's just a different study group. So you have, results, blanket results that you're carrying across different communities based on just a subset of the population. And that's sort of where my dilemma comes in, because from what I'm seeing in my community, different things are happening with the Black women I treat than what I'm reading in the textbooks or reading in journals. So I sort of have to take a different approach when I talk to women. I never push one surgery versus the other. I just let them know the experiences that I've seen amongst women within the community and let them come to their own, decision.
Yeah, I agree. I think, you bring up several good points. I mean, I think we've got to be a part of the trials in order for them to find out the answers for us. We can always try and extrapolate, and they've been doing that for years. And I've always just thought, this doesn't quite work for the women that I'm treating. And I'm really lucky now in that I'm in a health system where we have two hospitals that are in two different communities. I'm in the hospital that has a larger community of color, African American, Latino women, and other women of other ethnicities. And our sister hospital is in more of a white community. And one of the things that we're talking about is trying to do head to head. And I think just being able to do that, I think is going to really bring out some powerful information. I'm really excited about, looking at that, because just from what I see is, the cancers are different. And there have been studies that show even stage for stage, the cancers just are different. But we've got to figure out the what, the why, the how, and how can we make a difference when we move forward.
That's interesting. Stage for stage, meaning a stage 2 at your doctor's hospital could be different from a stage 2 at Anne Arundel, right? And I think I think from just what I know a little bit about your clinic in DC. So Dr. Hampton has a clinic, a mammogram clinic in Ward 8 of DC, where it has the highest mortality rate for breast cancer in Black women in the country, which is crazy, right? And she built a facility there to give mammograms. Even there, you're seeing more triple negative in younger women, right? Is that even different from where you are?
Yeah, absolutely. And, in Prince George's County, Ward 8, Ward 7, it's very similar just because the populations are similar. And it's, it's interesting because I think people thought, in Prince George's County that it was about access and insurance, and it's not. I have a very good payer mix. I see a lot of women, working women who have insurance, but the cancer, it's the biology of the cancer.
Yeah.
It really is the biology. And so we've really got to hone down and get that answer and figure out what the heck is going on. And nobody can figure that out but us as Black women. We've got to be a part of those trials.
So do you think that it's the stress levels, the diet, the way we live? Because some of us do live differently, right? Could it be that versus the way, Caucasian women or, a different descent other than, African descent lives? Do you think that could be the factor? Is that something that we should think of?
I think those are contributors, but we've got to have a way to measure it. So, that therein is part of the challenge. So I think a part of that study would be looking at those psychosocial, psychofinancial, issues and seeing, is that a contributing factor? I think just anecdotally, just sort of what I see every day, I think there is some truth, and I think those things are contributors. Certainly in Ward 7 and 8, there are a lot of food deserts. So the foods that those women in that community are eating, are not similar to the foods that the women are eating in Bethesda or, in some parts of Montgomery County. So, I think that has to be something that we have to really measure and hone in on as well.
Wow. So just means we need to do more research, right? So one more question, Dr. Gori. So you used to work at Hackensack Hospital, right, in New Jersey, which is a lovely, beautiful area, right? And now you practice in Newark. She actually moved to go to the people. Thank you for that. Right. But do you see the difference do you see a similar difference?
Oh, yeah.
More in Newark with more Black women in the practice?
Absolutely. I see in Newark, definitely younger women developing breast cancer. I do see a higher percentage of triple negative breast cancers. I see later stage. I rarely see a DCIS. I rarely.
That was me.
For those who don't know, that's a stage 0 breast cancer. No, most women, I'm seeing a higher percentage of later stage. I would say stage 2s and stage 3s. Compared to women in other communities, in more affluent communities. And this is even, comparing the Black women who are coming from affluent communities compared to the Black women who I'm seeing in Newark. So it's also, that difference in socioeconomic, whether, independent of whether they're Black or not, or African American or not. But there's definitely a difference, which goes back to the need for education in the communities that it's not stressed as high as it should be within our communities, and screening clearly. And just as you had mentioned, there's a different diet and lifestyle that's going on in more urban city areas versus suburban areas.
I think also the conversation is different in our two communities because, I can diagnose a white woman and she's like, all right, what do we do? What do we do? Black women, it's like, wait, what? Hold on. What? You mean cancer?
Right.
Wait, I'm not going to say the word cancer. I'm not claiming it. It takes me, time and really just time to really educate, to, talk her off the ledge. So it's just like, wait a minute, it's a half a centimeter. No, wait. So the conversation in our community around cancer has to change. I mean, y'all, we got to move up. This is 2021. We treat breast cancer a lot better than we did. Even with triple negative, we're doing better. But people are still back in the days of, I'm not going to hear it. I'm not going to see it. I'm not going to do anything.
Give it to God.
That's
accurate.
This week was my week of my patients who have been untreated. So I have a couple of ladies who are untreated. One has DCIS, diagnosed in 2016, untreated. So it's just, talking to her, having conversations.
It's so frustrating because our community is very chemo and radiation phobic, extremely chemo radiation phobic. That they are willing to go under the knife before even tackling the thoughts of chemo or radiation, and that's just, there's so much, fear and ignorance and just a lot of heavy duty explanation and all of that comes into play. And, unfortunately, a delay in treatment because it's going to, multiple sources, their family, their this, their that. No, I'm going to do natural therapy. I'm going to do this.
Yes.
So much as opposed to, white patients who, when they get the diagnosis from their primary, they already telling me what they're going to get. Oh, I saw this chemo treatment and, chemo before radiation, da, 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 da. They're telling me what surgery they want. They educate themselves so much more on their disease process that they're more receptive of trying to understand the different treatment options. Mm-hmm. So it's just on so many levels, we need more education and within the community for better understanding on, not only the diagnosis and the screening, but the treatment and the safety within the treatment, and knowing the alternative is surefire, death if you don't tackle it in a timely and an appropriate way.
I know.
Talk about help at home. Go ahead, Shalom.
I don't know about you, Ricky, but for myself, I know when I was diagnosed, I was like, okay, well, I didn't believe it at first. Like, really, me? Like you said, Dr. Hanson. Yeah, like really, because I'm healthy. I eat right. I think I do, and I'm healthy. But I wasn't going to stop there. I needed to find out how can I rectify this and rectify this soon. So, I know a lot of people that want to go the natural route. I know someone that went the natural route and they moved to stage 4. I know someone that was diagnosed 2 weeks after me. She's no longer here, but she wasn't active in as far as, she hid her, the diagnosis. She was, people knew about it, but she wasn't, I don't know, she didn't live, wasn't vibrant. And I think that once you're diagnosed, you have to be vibrant. So I don't know. I think that's why I believe you're still here too, Ricky. I know it was partially because of the double mastectomy, in your mind, I know, but I believe because you live a vibrant life. And I had a lumpectomy, but I live a vibrant life too. And I think that those two similarities that we live vibrant lives. Although we decided to go 2 different treatment ways, but we both live vibrant lives. And I think that has a great deal to do.
And that's interesting that you say that because, nowadays we encourage women to keep living life while you're getting treatment. I mean, as I was saying, my office manager, she continued to work while she was getting chemotherapy. So, I think, again, it's part of that changing the conversation in our community, because I think for those women who choose not to get treatment, I don't think they go to providers who take the time to explain to them in a way that they understand and that they'll be willing to get on board. And then B, I think, again, it's just changing the conversation in our community. What I tell people is cancer, they're bad cells, but we can have good outcomes. It doesn't mean everybody's going to do bad. They're bad cells. Let's do what we need to do to get rid of those bad cells. So it's really about that conversation. I would just encourage any woman who's out there listening, if you're with a provider and you don't feel seen or heard, or you're like, I don't know what this person's saying, go find another doctor. I mean, right. Especially in the DMV here, there's doctors on every corner. There's great institutions, here in our area and in New Jersey. So go see another doctor and hear, sometimes just hearing it a different way, sometimes just a different approach. My approach is I always want to know what's going on beyond the cancer. Because if you've got childcare issues, if you've got issues with your husband, if you've got issues with your job, those are things that me personally, I want to try and see if we can help you get through those. Because if we can't help you through those, you're not going to commit to treatment because you're so focused on everything else. And, it's very few doctors that are going to take that approach and really hear what that woman has to say. And I think that's so key. If you can't be seen or heard, go find another doctor. Fire your doctor. You can do that.
You say that all the time, fire your doctor, and I mean, Sybil got 3 opinions. You got 3 opinions from different doctors, but you said so many things, I think that we do, I love that you said we live vibrant lives, because I meet so many women who go into that black hole. But, we as Black people, we don't talk about health at the kitchen table. We don't talk about stuff. We don't talk about anything. Oh, grandma has the sugar until somebody gets sick, right? And then, oh, then they go, you know, what do I do about it? But we just don't have that like health literacy that we need to have. That's why it's so important to talk about it and talk to each other and know her story. Talk to your families about it. Even, you know, I remember that one woman in the clinic, Regina, that remember she was like 31, she had triple negative, and her husband didn't want her to have surgery. So she went for months without getting treated. And she was 31, 3 babies, right? Remember that? Remember her?
Mhm.
And I did the same thing to her. So, well, I don't try to yell at her. And then don't let me get near her husband. Okay. Really? But yeah, but she went for a long time. Like, what was she thinking? And because we don't want to deal, we just think it's going to go away, and close your eyes, it's going to go away. It's not. And we can fix it if we do the right thing. So it's just being able to put those conversations on the table. But I think, you know, the numbers like 77.3% of Black moms are single moms without disease. So think about when you add breast cancer to that equation, what do you have, right? And I know my breast cancer was caused by stress. I know it is. I'm actually doing a
Mine's
clinical,
too.
yep, I'm doing a clinical
Mine's too.
trial right now. It's Georgetown and Howard, and they're measuring my blood, something in my blood. You probably understand this better. Every quarter I go to get blood work. I have to go tomorrow to see the impact of stress on breast cancer, Black women breast cancer survivors. So
Oh, that's great.
you know,
That's
so
great.
you know,
Yeah.
I'm always talking about clinical trials, and so I wanted to really walk the talk. So that's why I'm doing one, and participating in this. But it's also, I want to understand, you know, did stress play a role? I'm in my spirit, I know that, but
Mine's too,
yeah.
Ricky.
We
Yeah.
also have to be cautious of who we get information from,
Yes.
because we're always willing to listen to the word on the street. The word on the
Which is
street
so
ain't
not
always,
accurate.
those on the block and don't necessarily have all the information. So it's like, you know, and my cousin got that chemo and this happened to her. And I always have to say, well, hold up.
Right.
What was the story? Because if your cousin had a
Mm.
lump and she knew she had a lump and she waited a year till she
Right.
went and got that checked out, well, that's a whole different
Right.
story versus somebody who's getting their mammogram. So we
Right.
have to look at reputable information. That goes even beyond just breast cancer. I mean, you know, the
Right.
word on the street ain't so accurate.
Right. Right. And you know, and also, you know, we're hearing from breasties, you know, when, you know, once you're a breastie, you know, it's unconditional love. It's a club you don't want to be in, but once you're in it, we love each other. But
Yeah,
we're not always passed on the right information either. You know, we
That's
got
true.
breasties saying, don't do a clinical trial, you're going to get the sugar pill. You know, I'm like, oh my God. So it's really educating everybody. So, you know, we're starting a movement. I'm starting a movement in October on clinical trials to get more women in. So we're working on it now. So you'll hear more about it soon, but we have to get educated. We have to get our young women educated. I think, you know, young women to me are our future, because like your daughter said, well, they're going to be the ones that come home and say, hey, grandma, did you get your mammogram? Hey, mom, did you get your breast checked? Hey, mom, we have to talk about early detection. Like, what are we doing about it? Because we need to start there, you know, because the old ladies aren't gonna do it. We're gonna be the ones in the cloud saying, oh, you know, I'm just gonna go pray about it and, you know, God will save me. And, you know, clearly faith without works is dead. My faith is what got me through this, but I had to work, had God work
absolutely.
doctors, right? Work through the knife that cut me, work through the
Absolutely.
whatever, you know, so whoa, we have a lot of work to do, but
Well said, Ricky. Absolutely.
And
yeah.
I had a patient who said something really great the other day. She said, you know, a lot of chemotherapies come from plant-based materials. So we talk
Yeah.
about, we want plant-based, we want natural.
That's a great
Chemotherapies
thing.
that are plant-based. You know, doctors, you know, are healers, you know, and so, you know, we've got to just get the right information. I always tell people when they come in and they're refusing, I'm not doing this, I was like, wait, just go and speak to the medical oncologist and hear the information. Go speak to the radiation, and you just give me one visit. That's all I'm asking. So you can hear from them what would be the treatment plan for you, what would be the side effects, what are the experiences, as opposed to, you know, you're going by information from 20 years ago and your grandma was treated 20 years ago and
Right.
XYZ happened to her. So again, we've got to get good information.
We do. We do.
I think the probably the craziest thing I've heard, I don't want to get chemo because I'm going to lose my hair.
And you know what I tell people? I say, look, all these people out here running around with wigs. Sort of back in the day, it was sort of that's the thing that your grandma did. But these young girls, they didn't feel like doing their hair, so that's
Yeah.
why they're wearing a wig. So we just would think you didn't do your hair that day. We don't know that you're on chemo unless you tell us.
Right.
Go
Right.
get some tattooed eyebrows and keep it rolling.
I was one to, I opted to go bald. That's why I actually sent in the bald
Me
picture
too.
because
Me
I
too.
wanted people to see that I was okay.
Me
I was
too.
okay bald. My hair grew back. It grew back different. I didn't know. I said, whose hair is this? But, it did grow back. So yeah, it's crazy when you hear these different reasons why people do not want to get treatments. So
Yeah, yeah. And the disease is not going away. It's
at
not
all.
going away by
No.
itself, and a couple weeks ago we had two naturopaths on the show, but they talked very specifically or adamantly about that being a supplement to treatment and a supplement to chemotherapy, or here's how we can help you make the chemo work better for you by taking these supplements or doing a plant-based diet or whatever. So they
Mhm.
never said, don't do the chemo. They said, eat the broccoli, do the chemo, drink the smoothie, do the chemo. So it's how do you make it, or use things like acupuncture or other things like a Reiki or whatever to help yourself feel better while you're doing the chemo. Hello. But
Or
And I
shop.
think we also should point out that not every person diagnosed with cancer needs to get chemotherapy. So,
Mhm.
there's some people who just do surgery and a hormone pill. There's some people who do, surgery and radiation only. So it's really important to get that plan that is for you. Not everybody has to get chemotherapy. If you have a estrogen or progesterone positive tumor, we have a special test to tell us if the chemo would even work for you or not. If that test tells us the chemo is not going to work for you, of course, we're not going to give you the chemo because it wouldn't do anything for you. So it's really a personalized treatment plan. And so I want women to come in and realize, listen to your providers and figure out what's the treatment plan for you. And it may be different. Ricky's plan is different from Sybil's plan, and that's okay.
right. And the key to me is early detection.
Yes.
No, we can't prevent it, but we can check our breasts every month. And, I always say, check the breasts that you love. I know you have a pair. I say that to men and women. And then, but early, if we can be on top of early detection, we can save a lot of lives.
And I tell people the two biggest risk factors are being a woman, ding, 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 and having breasts. Ding, ding, ding. The two biggest risk factors. So as women, we've got to be proactive, checking our breasts, knowing when something feels different, or have your partner do it, getting your mammograms, and talking about that family history, knowing who had breast cancer and what age. And you got to check dad's side of the family as well. It's important.
Yeah. Look at
And ask dad if dad had breast cancer. That's important to know as well.
Right. Well, that's like
Seriously.
Tallulah, our friend Tallulah.
Yes. Yeah.
She has a foundation called 2 for 2 Boobs. She's like, check your 2. But her dad and her mom both have breast cancer, and they have BRCA in their family. And I think she had 2 brothers and 3 sisters.
Yeah, and it came, I think the BRCA gene came from her dad's side.
Right. So they had it all through the family,
Yeah.
And I think her brother didn't want to deal, and I think he died because of that.
He
Right?
did. Yeah.
Yeah. So I don't know. What are we gonna do, guys? What are we gonna do?
Women are going to go out there, they're going to get their mammograms, they're going to check their breasts. They're going to, if you have an abnormal mammogram, I say just stop and take a deep breath. Go back, get the extra films that they're asking for. If they're asking you to get a biopsy, go ahead and get that biopsy, or go talk to a provider and see what's really going on. And if you're diagnosed, again, take another deep breath and realize you're going to be all right, and go get the right information so you can get treated and be a survivor like these lovely ladies.
Yeah, we're still here.
Still here.
Absolutely.
Not, yeah, still here. And
You're
I'll be here many, many years to come.
Yeah, many years to come. And I think even a lot of, what we, I talk to my daughters all the time,
Yes.
they're all in this with me, and they're with me through the fight. But but I actually just read a study too from that Yale put out, Regina, that and Gloria, that they're doing some research at Yale now on triple negative in Black women who didn't breastfeed their babies. And I know we've had this breastfeeding thing conversation for a while. I've never really studied it too quickly, but they're actually doing a study now. And Amanda's nursing my third grandbaby. I'm like, keep nursing that baby. She's like, giving her no, keep her on the boob as long as you can.
My daughter is nursing as well. She's 11 months in nursing, and I nurse her.
Right.
Yeah.
So we nurse, but if
Yeah.
that is something that can prevent or not prevent, but at least minimize your risk,
Right.
got to do it. So the more data we have, I think the other thing too is just getting more Black women into research, into these studies, like maybe not in the one in Sweden, but maybe we should start a study on mastectomy versus lumpectomy for Black women. Maybe we should start a study on, so we're kind of trying to figure out how we can best use research to help us. Like, what should we be testing? What should we be trying to understand better? I mean, are there any other things you guys think we should be understanding better?
Well, I think it's important to point out not every research study requires you to get medicine. There's some things where we just may want to monitor you and just sort of, you go about your normal day, you fill out questionnaires every so often, maybe get a tube of blood or two, but not every clinical trial do you have to take a medication. But I think we have to realize that the reason why we've gotten so far in breast cancer care is because there were thousands of women before today who were in clinical trials. This is why we can do sentinel lymph nodes and just take out a few lymph nodes as opposed to always taking out all the lymph nodes. This is why we can do lumpectomy versus mastectomy, because those women became a part of clinical trials. It's so important. And as Black women, women of color, Latina women, women of color, we've got to get in these trials.
We've got to. Gloria, do you know of any trials that are sort of happening?
Surgical related trials? No.
Yeah. I'm in this trial, and all I do is I go every quarter and get my blood taken. I fill out this extensive questionnaire about my stuff in my life, how many hours do you work out, whatever. And I'm happy to do it because I want to encourage other people to get into the science and so we can understand more, because I think we just have historically not been a part of it. We've not been a part of the trials, and it's just not good,
I wouldn't mind doing a trial. I mean, if you hear of any that would benefit my type of treatment regimen, I would be happy to do one.
Yeah, and doing surveys. So we just did this big research study and on clinical trials and their perceptions. And so now we've built a database of 100 Black women across the country. And so now we have access to women who want to participate in research, which is great. So we're going to figure out how to, get some funding to basically go back to them with different questions, different questionnaires, different surveys to just try to understand our disease a little better. And so that's a great asset. We're going to keep trying to build that database. So
you could, post that question to them with those 100 women. Start that, that survey, mastectomy versus, lumpectomy, what they chose, why they chose, what their, their different demographics, and start from there, just to, add to that conversation. I think outside of just the medical reasons or the socioeconomics, there's also our self-esteem and sexual health that contribute to our decision-making process when it comes to lumpectomy versus mastectomy, and also the various options we have made available to us for plastic and reconstructive surgery. Because, unfortunately, women in our communities aren't given the same opportunities that white women are given when it comes to options for breast reconstruction. So when they're just told your option is keep your breast versus, lose your breast without any kind of reconstructive surgery, they may be geared more towards one option versus the other, simply for the cosmetic reasons.
Right.
Independent of the health reasons, just for cosmetic reasons, because there's no other option to them, and they don't want to walk around without a breast. So I think, other things come into play when women make these decisions in regard to what surgery they choose. It's not only, based on whether or not their cancer will come back or not.
I know. Well,
And
and
I think
for
when you
me,
look at
oh, go ahead.
lumpectomies, there's so many different ways now that we can do lumpectomies. I mean, I have a lot of ladies who've always thought about a breast reduction, and actually their cancer diagnosis is sort of their springboard to get that breast reduction. So we can do breast reductions, we can do breast lifts. There's just so many different ways that we can do a lumpectomy now that meets the needs of a lot of women. So, again, it's just about really talking to that team and getting that information.
That's great.
The amount of tissue they took from me left, it was a lot. And they used my back fat and, slid it in. And you could, when people, I show people my breast, because I'll show somebody my breast in a heartbeat.
In a
It's so funny.
heartbeat. In a
Yeah,
heartbeat.
I'm like, yeah, I'm like, here, you want to see?
There you go.
Yeah. So, you can't really tell. They did a really good job, but again, I
And
just
even
wanted.
with mastectomy, I think a lot of women, there's so many ways to do mastectomy. I always say, grandma 20, 30 years ago had a different type, but you can get a nipple preserving, we could save the skin, you can get a 3D nipple tattoo. There's just so many options out there that I think, again, many times as women of color, the second we hear cancer, we're just shut off. We're not even going to hear all the options. And the second somebody says, well, mastectomy, we're shut off. As opposed to looking at the different options, we can do some pretty dang on good mastectomies that makes it probably look a little bit better than what you were born with.
Right.
They'll be lifted.
I love my little fake boobs, man. They don't sag. I don't have to wear a bra. I have to get mammograms, but also too, we wake up every morning and we look at our boobs in the mirror, right? And we wonder, is the cancer going to come back? And so part of it is, it's almost like, does it help to wonder? I mean, I don't know if I would wonder less if I had a lumpectomy. I don't know if I would. I mean, it's still in your head. It's in your head that, it could come back.
Every day. You do think about it. But what keeps me going is, God, you did it for me once.
Right.
You'll do it for me again. So I don't worry. And, I don't use the word remission. That's just not in my vocabulary at all. So I know that's something, people talk about, but I just don't use it at all.
Yeah, I don't use it at all. And then we have cherry blossom. Show your shirt.
Oh.
Yes.
So describe cherry blossoms. If you're in the DMV area, if you come here, you can go online too from anywhere to shop at this amazing, amazing boutique where you walk in the door and you are instantly a princess or a queen. Right. But
I tell you, I was inspired just by, the work I do as a surgeon. And I found that, nobody was really meeting the needs of women of color. When you talk about post-mastectomy and even post-surgical options. So we created a store that any woman can come in. I always joke and say, whether you got one breast, two breasts, saggy ones, anybody can come in and shop in our store.
And really big ones too, right?
Yes. Our bra size goes up to the letter O. And O is a real size, and some women need to learn that letter.
Wow.
But we also do prosthetics that meet the needs of different skin tones. So typically we're kind of pink and peachy, and we can color match just about anyone's skin tone, even white women who are not peach or pink, because they have different tones to their skin as well. So we're really excited. And then for women who've had a lumpectomy, if you have a little, what we call asymmetry, sort of it looks great after surgery, but then you get the radiation and years later you get a little shrinkage on one side. Sometimes you may need a slight prosthesis to even you out under your clothes. And all those items you can get through insurance. You can get post-mastectomy bras covered through insurance. Even if you've had a lumpectomy, you can get the prosthesis. You can even get the custom color match prosthesis. That's all covered by insurance. You can get post-op bras and post-op camisoles and things like that. You've got insurance, we may as well use it.
Right.
That's great. Can you speak to like you can have reconstruction surgery It's covered also, isn't it?
Yep, reconstruction is covered. That breast reduction and breast lift that we talked about, all that is covered under federal law. So there's a law enacted in 1998 that covers breast reconstruction. Even if you're having a lumpectomy and you do a breast lift on one side, then insurance covers for us to do, because you can't be all nice and pretty and droopy down here. Insurance covers for us to make you symmetric. If you had your surgery 20 years ago and you've got some asymmetry, you could come in today to a plastic surgeon and get symmetric again. So all that is covered by federal law. Every insurance, whether you have Medicaid, even the programs in DC and Maryland that are not Medicaid programs, but like part of the breast and cervical programs, they cover these items and cover reconstruction as well. So it should never be someone who has Medicaid is going into a doctor and they say you can't get reconstruction. Federal law, find me somebody who can do my reconstruction.
That's awesome. And people don't know that either. I had a conversation about that the other day. I had that exact question. So we have a lot of work to do to get the information out there, you know? Yeah. So so cherryblossomintimates.com, right? Whoops, I'm talking to myself. Cherryblossomintimates.com, right?
Yes. Yep, you can find us online. Yeah.
I love it. I love it. So, you guys have been awesome. Thank you so much. I was gonna see how people can reach out to you, but I was gonna say one more thing. So, you know, we're having our anniversary party on September 19th, and Dr. Agori is gonna come down from New Jersey, and we're gonna have people from all over the country, I hope, you know. So just know that you have to be vaccinated, and we're gonna wear masks. We're gonna be outside, but we're gonna dance on it. If you wanna come to our party, we'll put the link in our chat. Breasties can come for free, and we'll send you the breastie code. So tell all your friends if they want to come and dance with us, but we're excited to have our magic touch party. The other thing too is that we are hiring HBCU interns. So far we've had 8 interns this year, and it's a 10-week program. We pay $1,500 for 10 weeks. It's mostly on social media, and this internship is going to be helping us celebrate Black scientists who have contributed to our breast cancer cause. So we're hiring now. If you want to join us, go to info@touchbbca.org. Send us your information, and we want you to be a pre-health care student, so pre-med, pre-nursing, pre-psychiatry, whatever, pre-psychology, pre-whatever, but in the health arena, and attend an HBCU, preferably sophomores and juniors, but we'll talk to anybody about doing an internship with us. So our interns, they stay with us for life. They never go away. We have 3 of them have actually come back and done it again. And one of them came back to me and she was at Howard this summer. I'm so bored. Can I come work? And so she's working now, Sydney. So we love our interns. But again, I really believe that our young women are going to save us, because they all make videos with their moms as part of the internship, and videos with their friends. And really, we kind of force them to have a down and dirty conversation with their mamas. And most of them have never even talked to their moms about breast health before, these conversations. So we have to force it and make it happen at the kitchen table. Storm here. I know, and I'm telling you, these ladies, I will text them at 10 o'clock at night, 5 o'clock in the morning. Can you talk to this patient? And literally they respond in like 10 minutes and call the patient. So, you know, they are my posse. I love them so much that and they're always a resource to me for questions. So reach out to them, they will answer, or reach out to me and I will find them. Dr. Regina.
I don't know, I feel like you can find me everywhere.
I know.
You can find me on drreginahampton.com. You can find me at Doctors Community Hospital in Prince George's County, or Breast Care for Washington in DC, or Cherry Blossom Intimates.
Great. And if you are looking for a gift to give to a newbie, a new breastie, they have this really cool robe that is like the coolest thing for when you're having surgery. It has like pockets for the tube, for the nasty tube things. What do you call them? The drain.
The drains.
The drainage tubes. Ugh.
I've given that to so many women. It's like the best thing ever. But they also have like, you know, anyone can shop there and have beautiful lingerie. So, they have great stuff for surgery and dealing with it. So I thank you so much. I love you so much. Thank you for
Thank you so much. Thank you.
and
Thanks for having
talking,
us.
talking, and doing the work. Love you much. Breasty
Thank
love.
you.
Take care.
Breasty love. Breasty love. Bye.
Bye.
Bye.